Good afternoon, doctors. Team Kianite warmly welcomes everyone for today's assembly. We would be leading this meeting with a great honor as we encode and decode the war plan against COVID-19. We aim to provide every Kawani a better grasp of the strategies we employ in our fight against COVID-19 through a simplified discussion of the temporary or provisional clinical practice guideline that our country follows, entitled Interim Guidance on the Clinical Management of Adult Patients with Suspected or Confirmed COVID-19 Infection, version 3.1 as of July 2020. For the topic outline, we have organized the topics to 7 major headings as follows. Let us start with a review of the COVID-19 clinical presentation. Here we present to you several generalizations about the disease based on the current available research findings. As for the demographics, cohort studies have shown that there is a male predominance and most patients were hospitalized belong to the adult to elderly age group. Next is about the incubation and onset of symptoms. The median incubation period is 5.5 days, and symptom onset was observed to be at 11.5 days. Most common symptoms would be fever and cough. Aside from that, there is a table of other symptoms, and recent findings noted that there is a dysfunction of olfactory and gustation, meaning it could manifest as anosmia and ageusia. For the clinical course, a severe infection would typically progress to sepsis by the 9th day, leading to acute respiratory distress syndrome by the 12th day. The acute cardiac and kidney injury may happen by the 15th day, and at the 17th hospital day, secondary infection may ensue. And sadly, at the 19th day, it would ultimately lead to death. Meta-analysis showed that the incidence of ARDS is at 14.8%, and severe cases is 18.1%, with a case fatality rate of 4.3%. Here are the risk factors found to be associated with poor outcome. There is an increase of odds of death in older age patient, those with high SOFA score, and a D-dimer greater than 1 microgram per ml at admission. And also, there is an increased odds of in-hospital death for those with comorbidities such as diabetes and coronary artery disease. The course of critical illness for patients was found to have a median duration of 7 days from admission to ICU and finally to death. And more likely, these patients are elderly, those who receive mechanical ventilation, organ function damage, commonly ARDS, and hospital-acquired infections. Here's a table of complications, and as you can see, ARDS would be the most predominant outcome, which will be the most common cause of mortality, giving us a global mortality rate of 2 to 3%. And studies found out that there is a significant increase in fatality rate for elderly and for those with underlying disease. Now that we have a good clinical picture of COVID-19, let us now proceed to the diagnostic testing. The Provisional guideline suggests that diagnostic testing is warranted for all symptomatic individuals with suspected SARS-CoV-2 infection. And prompt or immediate testing would be leading us to proper PPE allocation, earlier prevention of spread, and would allow guided treatment and enrollment to clinical trials. Let us now focus on the diagnostic tests available for COVID-19. The guideline strongly recommends the use of RT-PCR assay with samples from nasal or pharyngeal swabs, sputum, bronchoalveolar lavage fluid, feces, and blood. Among these, the nasopharyngeal swab is the most preferred sample because of its good viral load and detection. There are two results of an RT-PCR, qualitative and semi-quantitative. A qualitative result of RT-PCR is sufficient for diagnosis, and it could be supplemented by a semi-quantitative result, which is the cycle threshold. And this would guide infection control, public health, and occupational health decisions because um, a cycle threshold provides doctors a clear picture of the viral replication. Aside from RT-PCR, there are other tests. For acute infection, we can use rapid antigen test. However, we must take caution when we utilize this test because it was shown that greater than 50% of patients of COVID-19 are not detected. This is very alarming, which may lead to false security to everyone who is using it. This may be due to various factors affecting its performance, from the test kit itself or the poor sample taken, among others. And its sensitivity vary from 34% to 80%. Due to these factors, WHO does not recommend its use for patient care. However, it may still be an alternative to RT-PCR at the first week of illness. And it is only for symptomatic patients. Take note, acute infection with symptoms. And the negative result from this should always be confirmed with RT-PCR before making treatment decisions. Another test would be rapid antibody test. However, its use is still being questioned because there's still no research about the persistence of antibodies following infection. Also, if it confers protective immunity against future infections. So further studies still warranted. If one would utilize this, two preferred rapid antibody tests are CLIA and ELISA. This test is best done at 3 weeks onwards from the onset of symptoms. The rapid antibody test is really not recommended because of its low sensitivity and high false negative rate. And it cannot be employed for standalone COVID-19 testing, mass testing, or even for work clearance for asymptomatic patients. Rapid tests that should be considered as effective, either it's antigen or antibody based, it must be FDA approved with a sensitivity of 90% and specificity of 95%. And only medical doctors would be the one who can prescribe and interpret the result. Now that we know the primary tests to use for COVID-19, let's now proceed to ancillary tests that can be helpful in managing COVID-19. Here we present to you the table of the summary and suggested diagnostic test for COVID-19. Let's start with low risk. Patients or those with mild disease. According to this table, there is none needed for these patients. What has to be done only is to do strict home isolation or in a quarantine facility. However, for moderate and high-risk patients, there are a lot of suggested baseline diagnostics presented in this table. These tests are necessary to early identify any derangements in the patient and prevent possible complications. Here, we would like to highlight the factors for us to consider these ancillary tests. The age being greater than 60 years old, pre-existing pulmonary disease, CKD, diabetes mellitus, hypertension, or cardiovascular disease, and lastly, if our patient has undergone transplant surgeries. Here are other ancillary tests that we may request for moderate and high-risk COVID-19 patients, with the following rationale of its use. After knowing the diagnostic and ancillary test, it is now imperative for us to have a clear understanding of the case definitions of COVID-19. Presented here is the old classification. Here now is the updated classification, wherein a non-COVID case is those neither a PUI or a PUM. A symptomatic case is those considered as a PUM. A suspect case is a PUI which is not tested yet. And a probable case is those considered as PUI, however, with inconclusive, inadequate, or no available tests. Lastly, a confirmed case would be those COVID-19 positive. To further characterize the case definitions, here are the complete criteria for each case. As for suspect case, this is a patient with fever and at least one respiratory symptom, either cough or shortness of breath, with a history of travel in an area with local transmission. And take note, no other etiology can fully explain the presentation. Or it could be a patient with ARI and contact with confirmed or probable COVID-19 case in the last 14 days prior to onset of symptoms. Or it could be a patient with SARI and requires hospitalization with no other etiology explaining the presentation. For probable case, this is a suspect case with inconclusive COVID-19 test. And lastly, a confirmed case is a person with laboratory confirmation of COVID-19 infection. Let us now define what a contact is. This is a person who had face-to-face contact with the probable or confirmed case within 1 meter and greater than or equal to 15 minutes, or those with direct physical contact and direct care without proper PPE. Now that we have a clear understanding of case definitions, let us now discuss the algorithms we use in managing COVID-19. First algorithm is about COVID-19 referral and triage. This is a modified from WHO. A patient presenting with fever and respiratory symptoms like cough and shortness of breath in the ER should be forwarded to a primary or secondary facility and be isolated in a single room or cohort, where initial assessment and management would be done, considering the comorbid and age of the patient. If the patient did not satisfy the criteria for referral to a COVID-19 designated hospital, then it is a mild case. Then the patient would be proceeding to home isolation or in a quarantine facility. However, if the condition deteriorates to moderate or severe, then the patient would be sent to a designated COVID-19 hospital, where diagnostic tests would be done, and if the patient does not meet the ICU criteria, then it would only warrant an inpatient admission and care at a tertiary hospital. However, if the condition deteriorates, satisfying the criteria for ICU admission, then the patient would be considered as critically ill and be referred to ICU. Precautions would be observed accordingly from standard precautions, droplet precautions, and specifically to airborne precautions. As the condition improves, patient would be referred back to less intensive healthcare facility until the patient qualifies for home isolation, and finally discharge. Next algorithm is the management of patients with probable or confirmed COVID-19 disease. It is important for us to first risk stratify the patient from mild, moderate, to severe. Mild patients would be those requiring only supportive treatment, and antibiotics would not be needed, and home isolation would be the primary recommendation for these mild cases. However, for moderate and severe patients, admission is warranted. Then, eligibility and willingness to be enrolled in a clinical trial should be inquired. Investigational therapies like favipiravir, dexamethasone, and others would be discussed further in detail later. Next algorithm would be the management of patients with probable or confirmed severe COVID-19 pneumonia. On severe condition, patient would be monitored continuously for worsening respiratory distress or progressing pneumonia. Then once it progressed to ARDS, patient would then undergo intensive respiratory management. And then investigational therapies may be employed in the context of compassionate use and clinical trial. Last algorithm is the respiratory management of critically ill and suspected or confirmed COVID-19. This algorithm is the detailed approach for moderate and severe critical illness of COVID-19, combining several guidelines such as the approach for ARDS, sepsis, and the latest available recommendations for COVID-19 respiratory distress. This is a good read for everyone, as this algorithm best summarizes the employed management guidelines for critically ill COVID-19 patients. In here, we can find the different criteria to consider in making treatment decisions and also the suggested management plans. Now that we have a good knowledge of the different algorithms of COVID-19, let us now discuss the different investigational therapies employed. The discussion will be according to the weight of evidence supporting the treatment recommendation. The evidence is classified as low, moderate, and insufficient. Let us start first with recommendations with insufficient support. Okay? Adjunctive treatments such as vitamin C and zinc have no proven efficacy as an adjunct treatment, as there are no clinical studies yet available to support its use. On the other hand, interferons have clinical studies with varying results, and it is still insufficient. However, it may still be employed in the context of clinical trial or compassionate use, as interferons make host cell refractory to viral replication. Next treatment recommendation for moderate COVID-19 with insufficient evidence is the use of favipiravir. This drug is known to interrupt viral replication. However, its efficacy against SARS-CoV-2 is still not established, as the preprint studies may have shown high risk for bias. Though it may still be employed in the context of, again, clinical trial or compassionate use. Shown here is the recommended dosing regimen for the drug. Next treatment recommendation are for severe COVID-19 with insufficient evidence are those that attenuate cytokine storm and strengthen the immune system. The first picture on your left shows hemoperfusion. This is the device that allows blood purification proven to effectively remove inflammatory cytokines. However, there is still insufficient evidence to really support its routine use for COVID-19. The second picture on your left is tocilizumab, a recombinant humanized anti-human interleukin receptor monoclonal antibody that inhibits signal transduction, thereby preventing release of cytokines. However, there is no completed RCT yet on its support for its use. On the right side, the first picture is a convalescent plasma, wherein antibodies from the plasma recovered COVID patients are administered to somehow help the body fight the virus. However, its use is still uh, lacking evidence to support the routine use for critically ill patients. However, in our country, its use is already approved for compassionate use among severe COVID-19 patients. And there is an ongoing clinical trial for it. The second picture on your right is IV immunoglobulin, which has a twofold action as neutralizing antibody and second as anti-inflammatory. However, there are no randomized clinical trials on its use among COVID-19 patients. But again, it can still be employed in the context of clinical trial. We now move on to treatment recommendations with low evidence. As for mild cases, there is a strong recommendation to employ supportive care and isolation at home. And there is no need for routine empiric antibiotics and anti-influenza drugs. Next recommendation with low evidence is the use of remdesivir for severe COVID-19 patients. This drug is known to inhibit viral replication. However, the study supporting its use is still pending publication of full report, and the result of ongoing WHO Solidarity trial is still ongoing. Though its use really is promising, shown here is the recommended dosing regimen. It could be used also in the context of clinical trial and compassionate use. Let us now proceed with the treatment recommendations with moderate evidence. It was proven in a systematic review that the use of hydrochloroquine or chloroquine were not associated with significant difference in overall mortality when compared to standard care. And so, neither monotherapy nor combination with macrolide or antivirals is not recommended for patients with probable or confirmed COVID-19. Also, it cannot be used for pre or post-exposure prophylaxis. Same goes with the use of lopinavir or ritonavir. These are not recommended treatments as preliminary result of trials showed that it has no beneficial effect among hospitalized patients with COVID-19. What is important for us to remember would be this: that there is a moderate quality evidence to recommend the use of corticosteroids, particularly dexamethasone, as adjunctive treatment for patients with COVID-19, requiring oxygen support and mechanical ventilation. Shown here is the recommended dosing regimen proven to be effective, which is 6 milligrams IV for 10 days. Lastly, the guidelines, however, does not recommend the use of inhaled, oral, or IV steroids as COVID-19 treatment or prophylaxis. Let's now proceed to the other recommendations and guidelines. First is the pre or post prophylaxis. The proven greatest prophylaxis against COVID-19 for healthcare workers would be observance of proper protective measures. First is the use of good PPE, and second would be ensuring good mental and physical health, which could be done by having rotation of health teams, good psychosocial support, a body system to really check the proper donning and doffing of PPEs, and lastly, proper management of healthcare workers who are exposed and providing them access to testing. The interim guideline also gives several interventions to implement so that we can minimize complications associated with critical illness. Here's the table provided by the guideline, which you may read at your own. Next recommendation is about repeat testing. First scenario is about after a positive COVID-19 test in a fully recovered patient. Test-based strategy is no longer recommended because RT-PCR positivity persists beyond infectivity. What is preferred for fully recovered patients would be time or symptom-based strategy. However, repeat testing based on test strategy may be used for specific patient groups listed as follows. Those who pose a risk of transmitting infection to vulnerable individuals, those who normally reside in congregate living facilities such as in prison or ships, immunocompromised patients who's on chemotherapy for cancer, prednisone, HIV with less than 200 CD4 count, and those with combined primary immunodeficiency. And lastly, those who have end-stage renal disease, diabetes mellitus, and advanced age. What we employ for this would be test-based strategy. Second scenario is after an initial negative RT-PCR in a still symptomatic patient. A repeat testing is strongly recommended for patients with persisting clinical deterioration despite adequate and appropriate management. And when no other etiology is identified, or in cases where samples were deemed unsatisfactory or insufficient. Next is the criteria for discontinuation of transmission-based precautions and isolation. This is 10 days after symptom onset plus at least 3 days without symptoms. However, for those specific patient groups requiring test-based strategy, as mentioned before, same applies. However, there's an addition of negative RT-PCR on day 14 after onset. And if it is still positive, repeat the test at least 24 hours apart until there is at least one negative result. Important criteria that we should never forget would that be of facility discharge as for immunocompetent patients. These are those who are clinically recovered that has no fever or use of antipyretics for at least 3 days, and also clinical improvement. And if there is mild to moderate illness, it is at least 10 to 14 days. Should have passed for now for severe to critical illness, it's at least 21 days. Take note, a repeat negative RT-PCR is no longer needed for these patients regardless of severity. Next is about the patient education to discharge patients. We must instruct our patients to continue observing protective measures like wearing masks, practicing cough etiquette, and physical distancing. And if there is relapse, like fever and other respiratory symptoms, patients should be resent to designated medical institutions. And a close follow-up is required, recording the address of the patient and informing the local government unit. What should we do now for those who are asymptomatic confirmed COVID-19? Well, as for immunocompetent, they should remain under home quarantine for 10 days or in a community facility. And there is no need for COVID-19 test at the end of their quarantine. As for those who are immunocompromised, special groups, or those who are positive upon screening or contact tracing, they should have a repeat RT-PCR as early as 10 days from initial positive RT-PCR test. And this must be repeated at least 24 hours apart until negative, and at least one negative result to discontinue their transmission-based precautions and isolation. We have to take note that if within 10 days, the patient develop fever or respiratory symptoms, we must extend the quarantine for another 10 days after the first day of symptoms. Recommendations now for COVID-19 healthcare worker returning to work. As for the symptomatic healthcare workers, the preferred strategy is a test-based strategy, wherein the resolution of fever without antipyretics should be met, and there should be an improvement of respiratory symptoms, and at least 2 negative RT-PCR with consecutively collected specimens with greater than or equal to 24 hours apart. All of this should be met for us to accept again the returning healthcare worker who is asymptomatic. You should have no fever, improved respiratory symptoms, and 2 negative RT-PCR tests. However, for asymptomatic healthcare workers, we could use either of the two strategies, the test-based and symptom-based strategies. And as for the symptom-based strategy, it is at least 10 to 14 days have passed since the first positive COVID-19 test. And lastly, here are the guidelines on advanced directives with regards to do not resuscitate or allow natural death orders for patients with severe COVID-19 infection. Healthcare workers may withhold CPR for critically ill patients with no reasonable chance of recovery. These include COVID-19 acute respiratory distress syndrome secondary to high-risk pneumonia and not responding to treatment, refractory septic shock, or multi-organ failure. The free and informed decision not to resuscitate must be made by the competent patient through an advance directive, and this should be followed. However, if there is no competent patient, an appropriate proxy can make the free and informed decision for the incompetent patient. And if in the case that there is no competent or appropriate proxy to provide the decision, the medical team can make the decision based on futility, best interest of the patient, and scarcity of resources. However, efforts must be made to provide spiritual care and counseling for the patient and family. Guidelines were from the 5 medical societies of the Philippines: the Philippine Society of Microbiology and Infectious Diseases, Philippine College of Chest Physicians, Philippine College of Physicians, Philippine Rheumatology Associations, and lastly, Philippine College of Hematology and Transfusion Medicine. Thank you for listening. We are Team Canite, giving you a message that kaya natin to.